Welcome to another episode of the Dissecting Medicine Podcast. My name is Jesse. I am a medical school applicant, and learning about all the different specialties is something that confuses the hell out of me, to be honest. And I'm trying to plan my career in medicine, as I'm sure a lot of you are as well. And so in this podcast, I'll be sitting down and actually speaking with doctors, specialists, and then also speaking to researchers, public health policy experts, as well as academics and people in medical education as well, to help demystify this kind of career path. Being someone who I'm almost 30, making a career change, I've always found career changes and career paths quite fascinating. And whether or not you're looking to go on to be a kind of practicing physician, or if you're interested in research, I think that having a more global understanding of healthcare and the contributories to health is something that makes us all better at the jobs that we're trying to do. So hopefully this is helpful, hopefully it's insightful, and hopefully it's entertaining as well. If you have any suggestions or you yourself would like to be a guest on the podcast, then you can email me at dissectingmedicinepod, P-O-D, @gmail.com. Otherwise, just get on any of my social channels and comment or send me a message and I will jump right onto it. Anyway, enjoy the episode. So I'll start with an introduction, I think, and I'll just read it off. So Dr. Travis Lines is a hospital medical officer at the Alfred Hospital. Travis completed a combined Doctor of Medicine and Master of Public Health at the University of Melbourne in 2020, and is currently completing a Graduate Diploma of Biostatistics at the University of Sydney and a Graduate Certificate in Public Policy at the Australian National University. Travis has dedicated much of his spare time to volunteering and working to fight social and financial inequities, with a record of volunteer work longer than we probably have time to itemise. Travis is fluent in Spanish and possibly Mandarin, I'm not too sure, and is likely the biggest fan that the Richmond Tigers have had yet as well. So welcome, Travis. It's great to have you on. It's really cool to just be sitting down and actually having a chat with you after how many years would it have been now?
Yeah, it's been a number of years. I think you've probably oversold my Mandarin, but it's a pleasure to be here. As I see some Richmond Tigers stuff actually sitting in my background as well, so you might have caught me there.
Yeah. Well, I remember the photo of you kicking the footy on the oval. I think it was after a Tigers game, or was it after they won the grand final? Maybe
it was. I was lucky enough to win tickets to the grand final, and at 3/4 time was invited out onto the oval to make a fool of myself. But the photos looked good, despite the fact that
it's iconic. It's brilliant. Yeah, how did the kick go? It didn't.
No, it was a kick for cash, and if I got it into the sort of the little Chemist Warehouse, I would have got $20,000. But suffice to say, I left with $1,000 in Chemist Warehouse vouchers.
Right. Okay. So that's why the shot was taken from that particular angle as well, maybe.
Yeah. If it had gone the other way, it wouldn't have been a good look.
That's right. It works out.
Yeah.
Cool. All right. And so if people haven't already caught it as well, for those who don't know, Travis and I have actually known each other for quite a while. I think we met in 2014, it might have been.
Yes, I think it was.
Yeah. So Travis and I, we were volunteering in the same project at UniMelb. It was like an educational outreach program, giving revision lectures to year 12s. I think we were involved in the biology team together in that particular year. We were co-lecturing and team leading that as well. And then we were working together in that project for, I think, about 3 years or so after that, before I eventually left. I think you continued on for a bit longer.
Yeah, that's right. You were my boss on the biology team. I was your assistant lecturer. Was my title.
Mm-hmm. I can't remember that well anymore. See, my age the memory's going on me now. I never actually revealed this to you either, and this sounds a little bit strange actually, but I've been very kind of proudly, I'll say, I don't want to think that I'm like a mentor to you or anything. I kind of see you as a mentor to me in a lot of ways, but I've been very proudly following your career, obviously watching as you went into medical school and then following as you went into internship at the Alfred and everything else as well. So it's honestly just very, very cool to be able to sit down and debrief on all of that and hear about how it's all been going, and to catch up after quite a few years as well.
No, that's very much, as I was coming onto this podcast, I was reflecting about sort of the impact that you'd had on, in particular, sort of the way that I lead teams now, because I've had a lot of opportunities since working with you to lead teams, and there's still a lot of Jesse in the way that I lead teams, and so it's very much a regard that goes both ways.
Perfect. I like it. It's cool. And so I think we were speaking a little bit before about kind of like the intentions of this episode and the podcast in general. So I think that being an applicant myself, I'm definitely interested in the experience of medical school. But I think because you're a couple of years now into actually practicing as a doctor, you're PGY2, which is postgrad year 2, and you've now got general registration. I figured that it's probably more appropriate to talk a little bit more about the actual practice rather than the medical school years, because it's a bit behind you now. And that's something that I'm really looking at a lot, is kind of planning out my career, also just still trying to work out and understand what life as a doctor actually looks like. Because I think we all kind of, at least I feel like I lie to myself sometimes that I understand it, but then I have to kind of check myself again and go, well, actually, you've never spoken to a doctor before. You've never followed a doctor around on a day of work. So I could have it very wrong. And I think that being prepared is one of the best ways to do things. And I think as well, it'll be really interesting for the audience to hear your insights as well, because it's happening right now. And you're also in that stage where you're probably starting to think about what the next few years look like for you as well in your own career. So that will be something that we might dive into.
Yeah. Sometimes I wonder whether I know what the day-to-day of being a doctor looks like. It's so very
Still questioning it.
I'll do my best to help you out and help you know
Sure.
what you're getting into.
Yeah. So I think I'll break it down. There's going to be kind of 4 parts. And the first part is, I guess, a little bit so the audience can understand a little bit more about you and kind of where you're coming from. So it does kind of draw you back potentially to med school interview times. I don't know how stressful they might have been for you. I'd imagine they probably were a little bit. And just to ask, I guess, if you could detail what it was that led you to the path towards medicine, or if you did have one of those kind of eureka moments where you realize this is what you want to do with your life.
Yeah, I think this is, you're certainly right. This has brought back the trauma of doing the
trauma.
This is often the very first question that we're asked is sort of why you want to do medicine. I think a lot of people sort of come in with the expectation that they have to treat medicine like a calling. There's some, profoundly deep moment of personal or family suffering that sort of brings them into medicine, and it's sort of been their thing ever since, or that they've come shooting out of the womb wanting to be a doctor. I think for me, it was a very gradual process. It still is a very gradual process, to be perfectly honest. It probably started off in primary school when my teachers kept telling me that I'd either have to improve my handwriting or be a doctor. And so I took the path of least resistance and became a doctor because my handwriting wasn't going to get any better. But then I suppose over the years, different nudges from people inside my life. I remember a teacher in year 10 really saying, look, this is something that I think you've got the sort of personal and academic attributes to do. You should really consider pursuing medicine, which really sort of sat in my mind, and it was something that I decided to explore. And across that process of exploring, I really enjoyed the process of learning science, of doing my biomedicine degree. I also really enjoyed opportunities like the ones that you and I had together in sort of helping people and that idea of service. And I also enjoy kind of communication and talking with people. And I think those 3 things together, sort of science, service, and communication, are kind of the 3 pillars of medicine. And so it's probably that combination of factors that eventually drew me into medicine. But look, it's, often we're sort of expected to be absolutely certain that that's where we're going. And there are certainly days where I'm still not certain that medicine is what I want to do. And that's true of many of my colleagues. But I think, when I sort of come back to those sort of 3 reasons, those are the things that remind me of why it is such a rewarding career and why I was so fortunate to be able to pursue it and now work in it. Right.
Yeah. And I guess it must be really nice to know that it is a culmination, because that's kind of the way that I describe it as well. For me, it feels, someone has asked me that before, like, why medicine? And we were talking a little bit before about the moment that made me click to reapply, but it's always felt like, for me, it's a culmination of skills. And for you, I guess it's a culmination of passions, so to speak, like things that actually excite you and drive you.
Yeah.
It must be nice to know that you've got like a history of validating moments that tell you, like, that keep, kind of goading you on and going, yes, this is the right path to be taking. Everything's kind of falling in place.
Yeah, I think sometimes, we're only human. Sometimes we need that sort of external validation at times to recognize and reflect on what's sort of already we sort of know inside ourselves, I suppose. And so,
Yep.
you know, you talked earlier, and perhaps your listeners will be familiar with it, about, you know, sort of your moment of having someone tell you that you should be a doctor. For me, that was probably my moment where I decided to pursue that as well. Was, you know, that teacher I alluded to earlier, saying
Yep.
that, you know, those moments can be very profound and really help to crystallize, you know, your own priorities in life.
Yeah. And that's a really good point as well, like listening to the feedback and the comments from others, because I know, and I'm sure everyone does, it's applying, and I'm sure you went through the same thing. When you actually do internally make the commitment, I think there's a lot of social pressure and a lot of social value that's put to medicine that doesn't necessarily need to be there either. You know, like ultimately it is a job. It has a lot of responsibility and everything, and it's a kind of arduous path. But ultimately it is just a career decision like any other decision.
Yeah.
And I think that a lot of people as well shy away from either making the decision, or they doubt the decision because they just assume, well, I can't be that audacious to believe that I'm the one that can be the doctor, because we've put so much social pressure on it.
It's one of the real disappointments of medical school in a way, is recognizing that doctors actually, you know, beneath their scrubs don't have angel wings, or, you know,
They're just regular people.
Regular people with regular people problems and regular people fallibilities and stuff like that. So that pressure is a real pervasive thing, and one I think that sees us put doctors on a pedestal in a way that, you know, does appreciate the you know, the important role that doctors play in society, but perhaps in some instances actually really pushes people away from medicine because they don't see themselves in that kind of role. They don't see themselves as being able to fulfill those kind of expectations, which, you know, in my experience, for most people is just absolute rubbish. Like, it's a job like any other.
Yeah. And that's the thing too. I think, like, speaking to people who are actually in medical school or who are actually practicing as well, that's how you really learn, like, oh, okay. So it's not to discredit anybody and their achievements or anything as well, but there is a real relatableness, like, is that even a word, to people who are practicing or have achieved, you know, entry into a medical program as well. It's, there's certain hurdles to jump, but it ultimately is not unachievable. It's not this kind of impossible high of highs kind of thing.
No, and you know, that's something that really stuck with me through medical school, is that you sort of go in with the expectation that everyone around you is going to be absolutely brilliant, and to be perfectly honest, in many cases they are, but, you know, there are still absolute tools. Like, but look, if they got into medicine, anybody can.
Anybody.
It's not a very nice source of inspiration, but sometimes we've got to take it where we can find it.
Yeah, absolutely. Yeah. And as well as that, like, I actually didn't know this, that you were doing. So you completed a Master's of Public Health, and then since then you've gone on, you're now pursuing further studies in biostatistics and public health policy as well. So was there anything behind what made you, because you did the MPH during medical school as well, right?
Yes, that's right. Yeah. So the MPH was an intercalated program, which you can do the MPH in 1 year as opposed to 2 years. The University of Melbourne was the first medical school to offer that, but it's becoming quite common and sort of following this very American model where you get to do sort of something else alongside medicine. And
is that similar to the integrated approach they've got now, where they're giving flexibility for, like, I think from 2022 entry, they revamped the med program to integrate PhDs and things if people wanted to pursue it. So it was similar to that, where you could.
Yeah, that's right. I think the MPH was sort of the first step in that process. But as far as I understand it, and from some of the discussions that I'd had with the medical school when I was there, is that they're really trying to move to this program that sort of allows you to sort of do whatever you like alongside your medical degree. So that may not just be a PhD and an MPH, which are kind of, I suppose, predictable destinations for a doctor, but also things like an MBA, which Master of Business Administration, or even if you want to do engineering or even art or something like that. They're trying to give people that kind of flexibility to add on other skills to their medical program, which I think suits some people really well. But I do worry that there will be a pressure to do something extra when that may not actually deliver the kind of benefits that people expect it to.
Yeah, because it feels like it's the Melbourne breadth model coming into the higher degrees, basically.
Yeah.
Almost. And I I mean, it could work out really well, especially things like an MBA, like for people who want to go into administration and that kind of thing. It makes a lot of sense to have that, and it's highly valuable. It'd be interesting to see, whether or not it's going to create another pressure, almost like when you're in year 12, the allure of the double degree, as if it's more valuable than a single degree. I see that with all of my students where they're like, but that one's a double degree. And I'm like, yeah, but do you want to do that second element and add it on? It'll be interesting to see how that goes.
I think that's the challenge though, right? Is that, you don't actually have to do that extra degree during medical school. You can, you sort of asked earlier about sort of the biostats and the public policy components. Like those are things that I've done post medical school. You actually can go back and you can actually combine outside study with clinical practice. I mean, it's hard, but plenty of people do it. In fact, the majority of people do it. So, I suppose, no one needs to do it just for the sake of doing it, but I sort of do worry that model will set people up to do that sort of thing.
Yeah, it's interesting. And I think as well, like with the biostatistics and public policy as well, and the MPH, what was it that kind of drove that decision to go down that path, even post medical school, to go back and keep studying in these fields?
Yeah, well, I suppose the government, during the course of my medical degree in 2020, I think it was, introduced a HEX limit. So you can only borrow so much money. In the case of a medical student or a law or dentistry student, $150,000 is your maximum HEX. Now, because most of my HEX is accrued before that limit, I'm nowhere near my cap. So I thought what I really need to do is I really need to hit $150,000 worth of debt. And so I'm just loading them on at the moment. No, none of that's true. The reasons, the HEX cap is certainly there. You'll never, ever, ever hit it. Although I am trying my best. Look, I think for me, the honest answer is that I'm just interested in those things. The MPH was something I did without really a strong sense of where I wanted to take it. And that was very much my experience of the MPH. Like I sort of did a little bit of different things and explored the things that I was interested in, mostly health economics. And likewise with the stats degree and the public policy, I've just got a really strong interest in public policy. I've had involvement in policy stuff through the Australian Medical Students Association. I've always wanted to sort of add to those skills and add some sort of heft to the work that I'd been doing. And likewise with the biostats, I understand that most people have a strong and abiding interest in stats. It's their favorite thing in the world, of course. But I think for me, I'm quite passionate about this idea of delivering effective healthcare and actually what looks like a good decision, what is a good clinical decision, and sort of to be able to make those judgments. I think the language of those judgments is statistics, and I suppose having those skills behind me where it will take me, I don't know, but it certainly helps with those kind of discussions that you have in medicine, that kind of decision making.
Yeah. So I guess it makes you a more effective decision maker, or to give you a broader understanding of the considerations, I guess, as to what to do next in particular situations.
I think so. I mean, a lot of what we're supposed to do as doctors, and early on in your career, it's not really true, but sort of as you progress through and develop more knowledge and understanding, sort of what we're meant to do is incorporate sort of clinical science in clinical practice. Now, it might surprise you and your listeners to know that we actually do that really poorly, in part because there are a lot of different factors that contribute to it. Most of it's just stubbornness, to be perfectly honest. But a real problem with it is sort of statistical literacy. People just don't understand how to interpret a study in a way that is relevant to their clinical practice.
Right.
Now, something that I've been really passionate about, something I've been really passionate about talking about, but it's really, really, really hard, I think, to prosecute that argument without really understanding the stats yourself. Like, it's not a good look to go around and say, look, none of you understand statistics whilst I don't understand statistics. It's just a defense. It's to make sure that I have these conversations in a way that is...
You've got some validation to it. Yeah, cool. And so I think now as well, moving on from that's kind of in terms of the education side of things, I figure we'll keep that pretty brief, but it's really interesting to hear that as well, because that's probably something that people don't think about a lot. And this is hopefully what I will do with this podcast more and more, is get those kind of insights and let people realize that the path to medicine doesn't have to be a stock standard, out of the box go to medical school, do the internship, to actually give those insights into what interests other people and why they make those decisions and what paths they take. So it's really, really helpful.
As much as I did do biomed straight out of university, I went straight into medical school though.
Yeah, I left that bit out of your intro actually, but
maybe this is just compensation, all of this extra stuff.
Maybe, so it didn't look too streamlined. Yeah,
exactly right. Just add some sort of interest.
Yeah, absolutely.
Yeah.
And so now, moving on, I guess part 2 is looking at the internship year and what that kind of entailed. So you completed your internship year at Alfred Health in 2021 last year, and of course, the UniMelb's MD program, they utilize the last 6 months, I believe, they call it like the pre-internship or preparation for internship, where you're effectively in clinical placement or on wards pretty much your entire contact time, right?
Yeah, that's right.
Yep. And so I guess how did it feel, or how was it? What was the experience like being on the wards as an intern, and you've no longer got the title or potentially the security of being a medical student, and you've obviously got a lot more responsibility. It's still a training program in a sense as well, but how did it feel to, I guess, be managing patients and working on the wards without the title of student and instead now being a fully fledged doctor?
Yeah, this sort of pre-internship model is a very common one around Australia, and so it sort of ends up meaning that as a final year medical student, you do a lot of the role of the intern, right? You sort of almost play the role as an extra intern, particularly as you sort of develop your skills, and towards the very end of the year, you essentially are the extra intern. But despite the fact that you sort of do that role as a medical student, it is still very different as an intern.
I had a feeling.
I suppose it's different in 2 ways, 2 really striking ways. The first is actually having that title. You alluded to sort of the security of being a medical student, which I think is an interesting point, right? It's sort of all power and no responsibility as a medical student. All power is probably not right. It's no power and no responsibility, to be perfectly honest. But the way that people interact with you is different when you are the doctor. Your patients, even whilst you feel like you don't know very much, and you feel terribly incompetent a lot of the time, which in some cases is true, right? We're at the start of our career, we shouldn't be expected to really know everything or be excellent at our jobs. That's in the nature of internship. Mm-hmm. But despite that being how you feel internally, the patients hang off every word you say. They really, really, really put their trust in you. I think more sort of almost overwhelmingly is when other staff in the hospital do as well. So nursing staff or allied health, they're now coming to you with questions and with the expectation that you will have the answers, that you make decisions that will guide a patient's clinical care. And in many cases, that's working with people who have worked in the hospital system for potentially even decades. Mm-hmm. And so that kind of, I suppose, psychological shift is one that I think is really profound, and one that can be quite overwhelming, and one that you really have to grapple with in some respects, because if you get sort of too caught up in your head, that's when you start to make silly decisions, because you forget actually that you don't know anything, and you should rein it back in a little bit. I suppose the other shift, the second really big shift in becoming a doctor is the way your sort of life looks like. One of the advantages of being a medical student at most medical schools is that you really do retain a lot of flexibility in your life. If you need to be somewhere in the middle of the week, it's usually possible. If you need to go home early in a particular day, your team is usually happy to facilitate that. So it means that you sort of can, as much as your life is very busy and you're on the wards a lot, you've got study to do, you are able to sort of dictate your life in your own terms at most places. I mean, there is one medical school in Australia that actually tracks its students and makes sure that they're coming to the hospital for 40 hours a week, which is weird. But otherwise, you really do have that flexibility, which you obviously lose as an intern. You can't not be there for your shift.
It's a job. Yeah.
You have to actually be there. It's a proper job. But, it's not all doom and gloom though, right? Because you obtain another kind of flexibility. I mean, most medical students come from very privileged backgrounds, but there are plenty who subsist on government payments like youth allowance or Austudy, which are, in dollar terms a pittance, right? You really don't earn anything at all. Whereas once you become an intern, I mean, in Victoria, you can expect to earn before tax about $100,000 a year as an intern. So going from sort of a $10,000 a year payment to $100,000 is a really profound difference in your life that gives you a different kind of flexibility, right? If a friend asks you out for lunch, you can go out and do it, right? Like you never had sort of pause. You never had that discussion of, we're obviously from Melbourne. There's no more Don Tojos, for example. Like you're able to sort of actually have that kind of flexibility with respect to your life in terms of, you might go out for lunch with a friend. You might even pay for your friend's lunch. Like it's a very different kind of flexibility, which I think actually compensates for the loss of sort of flexibility with respect to time.
Yeah. And it's really interesting as well, not to take it too far back to medical school, but the fact that you said that it's quite flexible in when you're actually doing your kind of clinic hours kind of thing as well. So does that mean that as you go through the degree, because the proportion of clinical placements or clinical hours goes up as you go from second, usually is when most people start clinical placements, some start in first, but as you progress towards that fourth year, does that mean that some would actually have greater flexibility in their schedule as they progress, ignoring perhaps the research project?
I think it really depends on the rotation that you're on and the university that you're at. I think in many respects, it's a cultural thing, right? Like really the expectation as universities describe it is that you should be there for 40 hours a week, like you are working as a doctor. The reality is that when you go on your placement, the people who look after you are people like me, like they're other doctors who know what it's like to be a medical student, who, can see that there's not much happening on the ward and the medical student is bored. And so there's a really strong culture within medicine to say to that person, hey, do you want to go home and actually enjoy your life rather than sit down and watch us write notes? Like, but there are some, like, for example, in my own sort of experience in medical school, I was at a particular clinical school that was, it had quite a sort of hands-off kind of vibe. And so it meant that you could sort of have that flexibility without the expectation that you would get told off for it. But like our women's rotation, which was at a different hospital, was very, very rigid. Like if you did not do absolutely everything that you're meant to do and be there every day to do it, then you couldn't really do it. So it's a mixed bag. It depends on the university. Obviously, like I said, there's that university that tracks you. I mean, that means that you have to be at the hospital for 40 hours. Like you've got no other choice. But yeah, it's sort of, it kind of depends, but usually there is that kind of flexibility there is the experience I think most medical students have.
Interesting.
Yeah, it's good. It's a good life.
Yeah, sounds it. Absolutely.
I think use of the flexibility of being a medical student, which I think actually made me a much better doctor.
Right. Yeah, compared to just being drilled down, just always like a 9 to 5 kind of thing for 4 years before you even start.
There's only so much you can do as a medical student on the ward as well, right? Like there is a point in the day where the doctors will spend most of their time doing paperwork, like writing notes or writing scripts.
Yeah, it's not like every part of the day is a learning opportunity, so to speak. And there'd be I'd imagine a lot of repetitive elements to the day as well. That's like, okay, you've seen that, you know how that works. There's no need for you to observe this element of the work anymore. Yeah. And so as well as that, I guess the intern year to me is something like I was saying before. Every now and then I think that I know what to expect, and I remember, no, I really don't. So to me, I think it's still very kind of mystical in a way, where it's this strange kind of intermediary year where you are technically working, you are a doctor, but you're also still in training in a sense, and you're still working towards a general registration as well.
Yeah.
So perhaps to kind of shed a bit more light on, I'll give a little bit of a relatable insight into what it's like to actually go through that intern year. Could you maybe detail some of the highlights and the lowlights of that year so people get a full understanding of the two ends of the spectrum?
Yeah, I think the intern year is an experience that is variable for different people, and the way it sort of looks is a bit different at different health services. But I want to reassure you and your listeners that, or you and your viewers, I should say, that the intern year is one that's very protected. Like, people understand that it's your first medical job. There's lots of support there, which probably is the highlight, actually. The highlight is that people do really look after you, which is very nice. And that probably dovetails with what I had always thought of as my biggest highlight of internship, which was working in teams. Like, it's just so much fun to work with intelligent, smart, that's the same word, intelligent, witty, passionate people. And I think I had a really good internship insofar as I was placed on a lot of really good teams. Like, all of my bosses were just very lovely, very supportive of me. Three in particular stand in my mind as just being absolutely hilarious, which is something that I particularly enjoy. Anyone who can crack a good joke is, I have very low standards, and that's the standard that I need from my bosses. So I think, that kind of camaraderie and that kind of the team environment of medicine is something that I think we really overlook as a real strength of working in a hospital. It's something that I've found that I really, 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 really put a lot of stock in. My low light would have been actually quite in line with that. I really didn't enjoy my rotation in emergency medicine. And that's despite working in what is probably the best emergency department in the Southern Hemisphere, with bosses who are extremely supportive in an environment that actually sees you, do real medicine, because a lot of the job of an intern is to do that kind of paperwork stuff. But when you're working in the emergency department, you're actually seeing patients and developing your own skills. But I just could not stand the fact that the emergency doesn't have a consistent team. You sort of work in this department without any windows, under the flickering halogen lights. It's extremely busy. You work in computers that you're sort of standing in the middle, you're very exposed. There's people all around you, but you still feel that sense of disconnection with the team because you don't know who those people are, and you don't spend long enough there to develop those relationships with people. And I think that was an experience actually that surprised a lot of people about their intern years, that they really craved that kind of consistent team environment.
Continuity. Yeah.
I was really quite shocked by how much that bothered me, that I didn't have that kind of continuity in a team, but like also a very good sort of lesson in what's important to me at the workplace as well.
Yeah, that's an interesting one, because it makes a lot of sense that would actually, it would take a lot of your confidence away, I would imagine. You'd almost feel like you're being thrown in the deep end when that happens, because you go from having a team of nurses, managing doctors as well, that you're working with probably every day for a period of time on a rotation, and getting to know them, building rapport, and then being able to trust people or knowing who to go to. And then all of a sudden you're in this very dynamic situation, and there's a lot more immediacy to the decisions that need to be made and that kind of thing. So it probably amps the pressure up.
Yeah.
I'd imagine you'd probably feel a little bit out of your depths in the first days or maybe weeks as well of settling into that, right?
I think as well, it's just when you're working on a typical ward job, there are always kind of moments of levity. You have those moments where you sit down with a coffee and you go through the list. Yeah. And sort of have a little bit of a chat. You get to know people not just as clinicians, but as people. And that's something that I really enjoy. Like, I like knowing who I work with and who they are and what they're about. Whereas in the emergency department, you perhaps don't get that as much, in part because you don't go and sit in an office away from the patients. You all sort of stand out on the floor where everyone can see you. And if you're all sort of just sitting around having a chat, as is a normal thing to do in a workplace, it's not a great look, I think. Right. So you sort of lose that kind of sense of connection to other people. And I suppose for me, I felt a bit more like a functionary rather than a person doing a job, because you don't have that consistent person sort of, checking on your progress, or, you're not developing that kind of longitudinal relationship with them.
Right. Yeah. And I guess that's where the choice of what you'd want to do, and we'll get to it later, but really comes down to personality type. Like, that's something that I've been reflecting on a lot lately, because I've always thought of myself as someone who, as much as I can dedicate myself to something for a very long time, I also know I have somewhat of a short attention span, and that's why emergency is some kind of emergency specialization has been something that's always interested me.
Yeah.
But then in terms of the value of medicine, it's like, what do I really like? And it's, I think, similar to what you said before, is actually learning about somebody and being able to connect with them and have some continuity, even if it's for a shorter period of time.
Yeah.
But being able to come back and see them and check that they're doing well, or, just building like trust, for example, with somebody where you're not building that same relationship in the emergency department because you're assessing them and you're probably then passing them off to the next department that needs to take care of them at that point, and then it's on to the next. And I guess that comes down to personality type of what kind of patient interaction you want and what adds value to the job to you. So,
which I think is, it's something that there are some people who just absolutely love emergency medicine that really suits them. And I thought it would probably suit me as well, actually, because I don't mind the idea of sort of helping someone in crisis and then, sort of being that person who, does the quick stuff and then hand it off. And hand it off to someone else, I suppose, or hand it off to another team that does the longitudinal work. Like, I think, when you talk about attention span, I wonder whether mine is a bit short sometimes as well. But as much as that term was probably the one where I learned the most skills and did the most development. It's not to to bag out the emergency department. It really surprised me how much the team environment was one that just didn't suit me. And so, as you alluded to, as it comes to sort of choosing which career you want to do, you sort of, in one sense, got to find your people, right? Like actually looking to who, what are the kind of people who are doing this specialty? What are the kind of people who are working in this field? That's actually a really important, by dint of personality, not by dint of sort of demographics and stuff like that. Because if you do that, orthopedic surgeons will be, old white men forever. But you've got to, actually, what are the attributes of this kind of doctor is, I think, a really important way to sort of help sort of crystallize which career path you want to take. And unfortunately, emergency is not for me.
Not for you, yeah. Fair enough. Yeah.
Skydiving or rock climbing, which I think is not adventurous enough to be an emergency doctor.
Yeah, fair enough. And as well as that, so a small one, thinking back to that first year internship, is there anything that you wish that someone had told you before you started it that would have been helpful to you, that could be helpful to people watching this now?
There's a career in journalism for you. I think one of the things that we do in medicine is we sort of trade on doom and gloom at times. Like, there is this kind of, which is really unfortunate. Like, there's this kind of thing where we trade sort of war stories to try and be the person who's suffered the most.
Right.
And it sort of foments this culture where everyone's like, oh, I did a, 14 trillion hour shift and I haven't seen my partner in 15 years and, blah, blah, blah. Yeah. Which is it's not the experience of medicine, right? Most days I go home on time, nothing terrible happens at work or anything like that for me or for the patients. Everyone's very lovely. I have an enjoyable day and I'm good and competent at my job, as are all of my colleagues, right, with a very few exceptions. No, I'm joking. They're all excellent. Really, actually all excellent. So I suppose the thing that I wish I had been told more often before internship was that it's good, that I will be good, and that it's a good time. Like, it's actually fun and enjoyable. You develop these wonderful skills. More importantly, you develop wonderful friendships with your colleagues who are all excellent. Like, I wish people spent more time talking about the positives of their experiences in interns, because when you ask people about internship, they're always like, oh, I'm so busy, this has happened, rah, rah. And inevitably you get them on a day that is a crap day. As unfortunately did happen when the intern taking over from me on psychiatry followed me around. We just had the most hideous day that day. It's like, I'm really sorry, this is not what it's like. But I think, as a habit for doctors, I think it's really important to reflect more and more on the positives.
Yeah.
Because, if it's really as negative as you're describing, and don't get me wrong, there certainly are problems with the way that medicine operates, and those problems I think have actually, as a point of discussion, emerged from just being a point of discussion within medicine. We've seen a lot of examples of those stories in the broader media as well. But for the most part, it is actually a very good job. It's a very fun job. Your conditions are usually pretty good. Right. And so I wish people would spend sort of more time saying that it's actually good. Like, it's fine. All the terrible stories you hear are not going to happen to you. If they do, you will be extraordinarily well supported. I think I wish people were a bit more positive coming into internship, because it is a positive experience.
Well, that's good to know, because like I'm someone who, I like a challenge, and I see the intern year as ultimately it is challenging. Like there's going to be challenges to it. But I think there was also an element of intimidation in there too that I needed to shake. So knowing that, like, overall it is actually a very positive, very enjoyable experience is a lot more motivating than this idea of, seeing it as the year that you have to get through to get to the other side kind of thing. It doesn't sound like it's really that's the case at all.
Yeah.
It more so just sounds it's a natural progression of training, and every bit of it is enjoyable. There are going to be bad days, or there's going to be things that don't go to plan, but on the whole, it's actually a very positive thing.
And it's probably, to be perfectly honest, it is probably one of the better years of your career in many respects. Like, I mean, I'm sure that most of the people watching will have a vague sense of the kind of medical training pathway, but once you sort of emerge from medical school and you get through your internship, at some point you have to specialize in something, whether that's general practice, surgery, whatever. And those years are very, very, very challenging, because you're taking on more and more responsibility at work and making clinical decisions that you are solely responsible for at much higher rates.
Yeah.
But you're also studying outside of work as well. Whereas an internship, you show up to work, you do your job, there's always someone to ask questions of, and then you go home. And when you're home, you sit there and you think, oh, I should do some study. Anyway, no, I don't have anything.
First time, there's nothing to do. Yeah.
I mean, to go back to one of your questions, that's why I had to do the biostats last year, because I
missed studying.
I was sitting there thinking, well, what do I do with my time?
Right.
This is so unusual.
Yeah, it would be, wouldn't it?
It's a weird experience. Like, it's really weird to, like, you in your spare time, you can go home and you can watch whatever you want on Netflix, or you can see your friends. Like, when you're not at work, you are free.
And study trains it trains that study guilt of, like, if you're doing something for leisure, that there is some penalty coming as a consequence, but there is no penalty now. Like,
it's awful.
It's such a horrible culture. Yeah.
It's terrible. Because, obviously uni doesn't, like, the proper uni semester doesn't start until March. And so for my first 3 months of the year, I'd go home and I'd be like, what do I do?
Yeah. You realize how many hours there are in a day all of a sudden.
You really do. Like, you sort of sit there and you think, God, this is a great show, but God, I've got to do my
something. I've got to write an essay, or I've got to yeah.
My house was extraordinarily clean in those 3 months, but that's probably my only
nothing else to do. Yeah. And so I guess moving on to part 3, from the intern year now into the kind of, we'll call it early career, because you're in PGY2, so you've finished the internship, you've now got general registration. And does the title change at all? Like, do you change your job position in that?
Well, it's the Pandora's box.
Right.
It really does. There's so many different names for what happens after internship. So
I get so confused. Like,
so you called me today a hospital medical officer, which is true. But so is an intern. An intern is a hospital medical officer.
Right. Okay.
They're a hospital medical officer 1. I'm a hospital medical officer 2.
I see.
Those people are also called residents.
That's what I wondered. I was like, is that an Americanism, or is that an Australian thing? It is.
May very well be an Americanism, but I've got no idea. Internship actually is an Americanism, though. It's housemanship in the British world.
Ah, right.
As a fun tidbit. But but then there are, like, if you're on a training program, then you might have a name there. So, like, the names that I go by would be hospital medical officer, resident, basic physician trainee, Travis.
Right. That's easy.
Those would be the job titles. Travis is not a job title. It's just the name I prefer people call me.
You can put it on a nameplate though. just that.
I found myself falling over at work with the weight of the nameplate with all those. But yeah, look, it's very dependent on really the way that most people would describe the progression in Victoria, at least. And I should preface this discussion by saying that all I've described is the names that we use in Victoria. You go to another state,
right? It's going to be different again.
So in Queensland, for example, you're a junior house officer if you're at my level.
So they're mixing up the housemanship thing with.
I think so. I'm not actually 100% sure that is correct, what I've told you, but I'm reasonably sure. And then at some point you become a senior house officer, but I don't know when that happens.
Right.
But nonetheless, the way that we often think about in terms of progression is you do internship, residency, which is kind of like internship, but with evolving responsibilities. But there's always someone sort of above you who is in charge of the team. Like you, right. You do a lot more clinical work, and that's been the nature of my work this year, right? Like I've done a lot more sort of seeing patients and stuff like that than you would in internship, and sort of making my own decisions. But it's still, you're not responsible for a unit. You're kind of the workhorse of the unit in many respects. And then you go on to registrar, which implies that you're sort of on a training program. It doesn't always necessarily mean the case, but that's the person who's making the decisions. They're running the ward. Essentially. And then after that's consultant, which means that you've finished a training program, you're a full box doctor, but you're not spending each day on the ward. Your registrar does the churn and makes most of the decisions. And then your job is to sort of support the registrar in making those decisions.
In consultancy, yeah.
In most places anyway. It depends on in ED, the consultants are always there. So
right. It is always a little bit different.
Yeah, indeed.
Yeah. And so now, because comparing, you were touching on it before, comparing to the internship year, what are some of the differences in your daily tasks or responsibilities compared to the intern year now that you're in PGY2?
It's very, very, very rotation dependent. So it depends on, what kind of stream you're doing and what rotation you're on. I think, what's been different? So I've done a lot. I'm on a relieving rotation at the moment. So I'm actually well placed to answer this question because I've done lots of different mini rotations. But I think the bigger difference is that you see patients more. So you might actually be the first person from the team to go and see a patient.
Okay.
As opposed to having, as an intern, you do the ward calls. So if someone, for instance, all of a sudden develops chest pain, you'll go and see that person and be the first person to see them.
I see.
But in residency, you'll do, for example, the admissions of a patient. So you might go and see a patient down in the emergency department who's going to come up to the ward and do a very long note about who they are, what they've come in with. Then you discuss with your registrar what the plan is going to be for that person.
Right.
And so you spend that sort of long time with the patient to sort of do that kind of process, where you don't really do that very much in internship.
Right.
With few exceptions. In psychiatry, I did that a little bit. And there are some roles as well where you actually might be providing advice to other teams. So we have a diabetes resident, for example, which is just the most glorious thing in the world, who basically, if your patient is on the ward and their diabetes is really challenging to control, this resident will come in, see your patient, and tell you exactly what to do.
Oh, wow.
And I'm magical.
Brilliant.
But that's a job that you can do as a resident, where you're actually providing advice to other teams.
I see. Right. And so that means, so as an intern, you wouldn't be doing any admissions of patients. I guess there would just be someone, probably a resident, has already admitted them, got their history, and then you're kind of being run down on what their case is, and then being involved in the management and the decision making almost.
I think that's largely, it's largely true. It really depends on the hospital service, and it depends on the nature of the role. There are some hospital services where interns will do lots of admissions and stuff like that. But my service is one where internship is particularly protected.
Yeah. I guess it comes down to staffing as well, like the number of staff they would have and the relative number of patients as well, like in terms of how much responsibility you might be handed.
Yeah, I think, look, again, it really depends on the role, but often you'll work with a team that looks after all of the patients together. So, the structure of a team on a medical ward essentially meaning general medicine, which doesn't exist in some states. New South Wales doesn't have it. But like cardiology, any of the organ specialties, right? Like lungs, hearts, kidneys, whatever you like.
Yeah.
Well, be a consultant, a registrar, sometimes a resident, and often the intern, and you sort of look after them all together. But the degree to which the intern takes on responsibility is less than what the resident would take on.
I see. So that's that's the big distinction, is just the responsibility of decision making more than anything. Yeah.
Look, there are some units that don't have interns where the resident does a lot of the role of the intern, right? So the unit that I go on to next doesn't have interns. And so it means that I'll be the one writing the notes. That means I'll be doing, a lot of the paperwork and stuff like that.
Right.
Which, those are roles that the intern would perform were they on that team. But it also means that if my registrars are busy, I just whip downstairs and do the admission and, that sort of stuff as well. So the other big change actually at my hospital service is that our interns don't do night shift, which is
okay. Glorious. I would have thought that would have been part of it, almost like when you're driving and you're racking up your hours on your L's and you need to do a certain amount of night hours.
No, it's definitely not actually, which is, probably safe, to be honest. I think as an intern, it would be really challenging to do night shift.
Yeah.
It's really challenging as a resident to do night shift, to be honest. But that's a big difference is that we do.
In terms of the working environment, or in terms of just adjusting to like going backwards and forwards between day and night shift?
I think, if anything, the interns would probably be better at the adjusting because they're younger and more
able to bounce back.
They can bounce back quicker. Particularly, my hospital tends to take students from that have done an undergraduate degree, so they're all very young. Compared to me,
right?
Which is something that you'll obviously experience when you get through as well.
I'm starting to think like maybe the Alfred is. I'm going to try and get an internship at the Alfred.
The benefits of youth.
I'll be 31 by that point. So.
But I think night shift is really about putting out spot fires, right? So the two roles that you have on night shift are to look after the wards, and that essentially means to make sure that people are sort of, as problems arise, you have to solve those problems. And there are people to support you and ask questions, but, the pace is very quick. And the other role of night shift is to go down to the emergency department and admit patients who are coming up to the ward.
I see.
And I think without a really, at least some kind of clinical acumen developed through practicing medicine, it would be really difficult to work through night shift. Like I've had a couple of friends the last 2 years who have started internship on night shift.
Started on
it would be
first rotation is on night.
First day of internship started at 9 o'clock at night.
That's scary. That'd be terrifying.
I think it would be really, really, really challenging. I think that I think the nature of that night role is probably easier than would be given to a resident. Just acknowledging the kind of as it should be, right? But nonetheless, it would still be really tricky. It'd be tricky for the other staff as well. I remember, like my first day of internship, I would ask about what dose of Panadol to give people, or like
that'd be managing a lot more questions where they're less like understaffed, or maybe not understaffed, but less staff on hand and things. And then you've got, what about this? How do I do this? What about if this happens?
That's exactly, and that's how it should be, right? Like
it should encourage
have that kind of, medical students can't prescribe, and so you are so worried about making a mistake or not knowing how to do something that you do ask lots of questions, and people are excellent about answering those questions for you, which recognizes the kind of, I suppose, the position that you're in. But starting on night shift would not be my ideal recommendation for interns.
Right. Fair enough. And so in terms of your work schedule, so you mentioned a few things about like now that you can do night shifts. I actually, when I first messaged you the other week and you replied back to me and it was like 5 o'clock in the morning and you said, I'm just at the hospital now. And I was like, oh, wow. So I wanted to ask like what an average, it may change obviously, but like what an average weekly schedule or like kind of work schedule looks like, what kind of things you'd be doing in a day. If you could give like a kind of brief kind of rundown of what that actually looks like.
So this, messaging at 5 o'clock in the morning and telling you that I'm at the hospital is part of this culture of saying, oh, look how bad my life is. I wanted your respect and admiration for
right.
being at hospital. But as you alluded to, the schedules are very variable, but essentially very rotation dependent. So the standard working hours for a doctor is 38 hours a week. And there are some units, particularly medical units, that will keep to that. So you do Monday to Friday. You might do some after hours or weekend jobs as well, in addition to that. So you won't do it every week, but you'll do, you might, rather than staying to 5, you might stay until 9:30, once a day every fortnight, and you might do the weekend once every so often. So that's, I suppose, the basic hour. If it's on a surgical term, surgeons start a lot earlier in the morning. So you'll maybe get into work at 5:30, 6. And often the hours are very long. So some hospitals will work until 3 o'clock. Some hospitals will actually have you there until sort of 6 o'clock at night every day.
Right. So does that then maybe knock a day off instead? Like, do you then have 4 days if you've racked up at 38, or does it just go as overtime?
It really, really, really depends on the hospital service. Often a lot of hospital services are very reluctant to schedule people for that amount of overtime, so they just put more doctors on. My surgical term, we would do 4.5 days a week, right? So we would do, you would leave at sort of midday on one of the days. But, you'd also do an after-hours shift each week as well, where you'd stay until 9:30. You might do a weekend as well, just one day on the weekend. So lots and lots and lots of overtime is what you do in that case. Obviously, there's night shift. Night shift, you will do 7 days in a row typically, where you'll work from sort of, let's say, 9 o'clock until 8 o'clock in the morning. Or till 8:30 in the morning, and you do that for 7 days in a row. Then you'll have some days off. And then sort of, I suppose the last kind of structure to talk about is some units run what's a 7 on, 7 off roster, where
I've heard about this.
Where you sort of, it depends on the unit, but for example, you might start at 8 o'clock in the morning and finish at 6, and then you'll do some after hours cover, and you'll work over the weekend as well, and you'll do that for 7 days in a row. Sometimes only for your 38 hours. Sometimes you'll do some overtime. Or sorry, not 38 hours. Obviously, you'll do 76 hours in that case. But then you have 7 days off.
Right.
And you might be on call for one of those days, which is a standby on call, where you get called in if someone's sick.
I see. Yeah. Because that's something that actually really appeals to me, because it's actually very similar to my own work schedule, where I know that I was working 16-hour days for a long, long time. And now I'm in a stage where it's like, I don't work as much right now, but I'm doing like on off by months. So I do a couple of months on where I'm working really, really intensely. And then I have a month and a half or so where I work basically part-time instead. And I'm doing that one to see if that improves my productivity and my general like mental health. But it's also like testing if the real kind of on-off switch is a long-term solution as well. So like the 7 days on, 7 days off to me seems ideal.
I suspect
it comes down to how people like to work as well, like what suits them.
My suspicion is that it's probably not a very good way of rostering people, insofar as we know that productivity diminishes the more sort of work that you do, which is just right. And there have been studies in the past that have looked at sort of what number of hours you need to do in a shift before productivity, like your marginal productivity, actually becomes negative, which is a worrying. It's like 21 hours, I think. But in any case, like I'm not sure it's the most productive use of resources, but as someone who works those shifts, I also really liked it. Like it was really, the one gripe I had with it was that I had 7 on, 7 off during a COVID lockdown. So I couldn't really use the 7 off, but there are people who, there's some doctor I've heard of who would work 7 on, 7 off and would spend his 7 off like surfing in Bali or something like that.
And then come back to work for another week. Yeah.
Which, at the moment I'm meant to have 5 off because I'm actually on a 7 on, 7. So I actually meant to have 7 off, but I'm on call for one of them because I'm on a 7 on, 7 off. And I was going to go to, like I was going to go overseas for, to Singapore for a while. As you know, but your listeners don't, I've actually got COVID at the moment. So those plans have been
off now,
so far from sort of broadening my horizons, they're currently confined to about 50 square meters as opposed to 15,000 kilometers, I suppose. But like that kind of flexibility is really, like, so I've got some friends over in Singapore I haven't seen in a couple of years. Like you get to do that sort of thing with 7 on, 7 off, which is really cool.
Yeah. I think the flexibility of it is very appealing. It would probably be a more effective, but then it would just become so chaotic to actually manage the schedule if hospitals could, like, it just wouldn't work though. I think it'd be too complicated, because the 7 on, 7 off, I think, is very effective for people who work well on that schedule. But then not everyone is going to be able to do 7 days in a row where you're working 12 plus hour shifts and things to make up that time. So maybe it's like an averaging thing, like it's averaging out. Like there's going to be some people that are slightly less effective, but they're in a team. You've got other people that are thriving on that system, and it maybe allows them to prepare resources a little bit better for, like, to make sure they've got staff at a particular time if something goes wrong. Or I'd imagine that's maybe what's behind it.
I think, you're absolutely right. My suspicion of the reason that we do it is because it's very convenient in terms of how the rostering goes. Like, it's very easy to build a roster that's 7 on, 7 off, whereas a weekday roster where you've got people sort of having to do the after hours cover in a kind of inconsistent pattern is less easy, I think, to manage. It's definitely tough. Like the 7 on, 7 off is a hard week, particularly for the registrars who do it, who actually work more hours than the interns. Like the interns really only just do they might do 80 hours in the 7, which is not really a lot. Whereas the registrars will do, like, every day will be sort of a 13-hour day, which is hard. But if it suits your kind of work style, which I think for me it probably did a little bit. Like, I don't mind just grinding through. It's pretty cool. Even in COVID lockdown, like you get to sort of, you do all your cooking for the week. Like, you can get outside and sort of do your 2 hours of exercise and stuff like that.
Get in those 2. We had one at one point, didn't we?
Yeah, we did in the 5-kilometer radius.
Fun.
Like it actually, and it means that you come back to work very refreshed and, and are able to sort of, I suppose, indulge the kind of hobbies and interests that you might have in a way that isn't necessarily available to you over the weekend. Right. I mean, part of the advantage is it's during the week as well, right? So you have your weekend days off, but you actually have an opportunity, like your friends are all working and stuff like that. So you have an opportunity to sort of do things that you want to do with yourself and for yourself. So it's quite nice.
Yeah. Because that's something that I've reflected on. Like my job, obviously, I mostly work afternoons and nights.
Yeah.
So working with high school students. So unless I'm choosing to put more work on during the day, like I'm just about to finish a kind of quiet month and a half that I've had. And in that time, it's like Monday to Friday during business hours, I don't have anything on, which means like there's so many advantages of just like really simple stuff. Like you can go to the shops and there's no lines. And that, like little things like that, you can run errands really easily. And you can just make use of there being like, it's just a lot more quiet as well. And I think there's a real value to that sometimes as well when you're in that off time. And I'd imagine having the 7 on 7 off, having weekdays where it is genuinely quiet because everyone is at work is probably more peaceful sometimes than having your weekend every week. But it's also busy. If you want to do something, it is busy. Or when you're at home and there's lots of people at home around and that kind of thing as well, if you really like that kind of quiet time. Yeah,
it's pretty, I mean, particularly now that things are sort of coming back, it's pretty nice. Like it's nice.
I was hating it during the lockdown. I realized I just took for granted what it's like to be at home on a weekday and just really, because obviously I'm in an apartment as well, and it's just like have nobody around, and it's just so dead silent all day. You forget what that's like when suddenly everyone's at home and there's always noise.
Yeah.
Oh man, I can't wait for this lockdown to end just for that.
I'm very glad that things are opening up, and like there is something really nice about a busy city and stuff like that. I mean, I was at the MCG the other day and there's like 70,000 people there, which is really cool. But my radius includes the CBD. And like, so being able to like there's a couple of little cafes there where you could go and get like a takeaway.
Yeah.
Like, not a big coffee drinker, but like a hot chocolate or something like that, or something to eat. No line.
It's brilliant. Yeah.
Scoot straight in, like it was just blissful. But no, I think it's, I'm sure those businesses would be much happier with the lines.
With a lot more customers. Yeah. Yeah. And so as well as that, just moving on, looking, I guess, a little bit more prospectively now for your own career, something I mentioned before that for me, I might be jumping the gun, I don't really know, but I'm someone who likes to prepare for things, is I'm looking a lot at what kind of specialty I want to do. Because I think initially I didn't really have anything in mind and thought maybe I don't ever want to specialize. But I think for what drove me towards going, no, I want to choose something is a bit more career stability and a bit more freedom as well. Like you get a little bit more control when you actually move into a specialty compared to, say, staying as a ward doctor the entire time. Not to mention that there's obviously a gigantic pay increase when you go into a specialty as well. You're obviously in your second year, so most people seem to do either that year and then apply to a specialty college, or as well as that, pretty common to do a third year and then start to look at applying. Is specialization something that you've been thinking about or starting to prepare for?
Well, actually, for posterity, what do you want to do? I want you to have this little time. So you can look back when you're a brain surgeon and go, oh God, what did I do?
Definitely not neurosurgery. There's, at the moment, I think that I'm still very undecided, which makes me realize that I definitely want to experience medical school and probably internship before I really start making a decision. But the few that are on my mind is they seem very cliched, but I was looking at mixing pediatrics with emergency and actually looking at like pediatrics intensive care or pediatric emergency. And the other one that I was looking at as well is just internal medicine, because I've got two real ends to what interests me. So one is the very rapid, like quick decision-making, crisis management. And the pediatrics thing was because I never thought I was someone that was good with kids, but I never really grew up around little kids either. So I never had that exposure. And then working as a tutor, I just kind of realized I started working with mostly teenage children, and I really enjoyed it. And I realized that I could build a rapport really quickly. But then even working with very young children that were 6 years old and that kind of thing, and I got feedback that I was really good with them, that they really enjoyed it. And I really enjoyed just playing, like kind of just doing my job, but also just engaging with them and, being able to educate them at the same time and really build that connection was something that's made me really think about pediatrics. And then the other side of it is just that like every part of human health and the human body interests me. And that's why just general internal medicine is also something that I just go, maybe that's what I should do, because I don't have to make a decision of what part of the body I want to really focus in on. And I thought about my job as a tutor. Like I've never been a tutor who only tutors one subject. I've always enjoyed tutoring anything and everything that I can, and knowing a little bit about a lot rather than a lot about a little. And I think that's something that just suits my personality. I'm happy to not have a really deep understanding, right down to like you're talking about the diabetes resident or whatever, and just knowing like all the random names of enzymes and what they activate and this and that. That doesn't necessarily interest me. But being able to manage any type of patient is something that interests me. So those are kind of the two that are probably front and center at the moment.
It'll be interesting to see how those preferences change when you...
They will change. I am
absolutely.
very sure they will change.
Absolutely. When I started medical school, I wanted to do a specialty called clinical pharmacology, which I don't really understand what it is, to be perfect.
I could,
but it's a subspecialty of like, we'd call it physician medicine, but internal medicine is probably the right term. That essentially is concerned with this kind of, the use of the careful use of drugs, essentially, which, really was something that, I sort of alluded to earlier. Like I like this idea of, how do we make good decisions and stuff like that. And a lot of clinical pharmacology is directed towards that as kind of their role, right, is providing advice about how to make smart choices and how to synthesize evidence to make smart choices. But in practice, I just don't really know it's not very, it's not a very common sort of, I only know two people who have done the specialty and they both do something else as well. And so it's sort of hard to see what the specialty actually is and that sort of thing. But in any case, it's not what I want to do anymore. So those preferences change because you have this, it's written down on paper what the specialty is, which is how I've described clinical pharmacology. But in practice, you often end up working in a gen med role, which is sort of looking after, usually elderly people with common presentations on the ward, which is not something that I'm particularly, I don't love. I don't hate either, but I don't love it. So, often the practical sort of side of things of what actually looks like. Some people, for example, go into endocrinology with the expectation that they'll, be, looking after Addison's disease and Cushing's syndrome and, all sorts of rare kind of brain tumors that are spewing out hormones whose names and actions I can no longer remember. But, the reality is the majority of the role of an endocrinologist is to look after diabetes. And if you don't have an interest in diabetes, you shouldn't do that specialty.
Yeah.
Or you should be really, really, really brilliant and find your sub niche. But, for most people, it's not possible. So,
it's not possible. Yeah.
I suppose for me, look, the way that sort of specialty training pathways work is, again, very varied. I feel like that could almost be the tagline of this conversation, a variable chat. About how varied you might make that the tagline, yeah. Well, you sort of got to now. I've given it to you. I'm sure you can do better than that. But the broadly speaking, there are sort of various streams that you can go to in residency, which sort of set you up for different specialties. So there's a surgical stream, very, very obvious what that leads towards. It leads towards surgical specialties.
Yeah.
There at some places there's a critical care stream, which leads towards ED, ICU, and anaesthetics. There's a medical stream, which sounds silly, but the word medicine within medicine means something different to what we understand it. Right. Medicine refers to internal medicine. It's those sort of physician specialties that we talked about earlier, the organ doctors, as I like to call them. And so that heads towards sort of internal medicine normally, or sometimes ICU as well. And then some hospitals, in fact, most hospitals will have a general stream where you can do often some pediatrics, women's health, psychiatry, etc. In terms of when you actually apply, or general practice, obviously from the general stream. In terms of when you apply and when you start doing things, I mean, it's really, really, really challenging. There are some specialties that you sort of have to decide that you want to do in medical school.
Right.
Like to be an eye surgeon, extraordinarily competitive.
Yeah.
You'd really want to sort of start to build an interest in that specialty whilst you're in medical school, develop some relationships. It's not impossible to sort of decide after medical school that you want to do it, but that's sort of...
You've got to have the wheels turning almost for that.
Yeah, exactly right. And so in terms of when you apply, it really depends, right? For some people, it's only a few years out. You'd usually do a couple of years of surgical residency and then get onto the program. For other people, it takes a really, really, really long time. They might be a surgical resident for, up to sort of 7-8 years.
Right.
Often those roles, though, are sort of unaccredited registrar roles. So you'll actually work as a registrar. You get paid a registrar's rate, but you're not on a training program. So that's, I've used eye surgery as an example, but that's true of most surgical specialties. In fact, eye surgery is probably one that's a bit more linear. Like I've got a friend who's just started his training. I think he's PGY4, which is pretty quick for surgery. But something like orthopedics, general surgery, you'd often sort of be PGY 5, 6
before you're onto that.
8 or 9 by the time you're sort of building a sort of resume for that. For medical streams, it's usually pretty quick to get onto the training program. You do your basic training, then you go on to your sort of advanced training there, which is where the sort of difficulty in applying happens. So, other things that can sort of be a few years. It's a whole schmozzle. It's a really loaded topic that is really tricky. It shouldn't take this long for people to be on a training program. It's a waste of time and resources to have people sort of floundering about in the hospital outside of a training program. That stability that you've alluded to is a really, really challenging thing not to have.
Yeah.
So for me, part of my pathway has just been trying to create that stability without really being sure about what I want to do. But often the rule book I sort of use is if I had to choose today, I would choose infectious diseases, which is obviously, as people keep describing it to me, is a real sexy specialty at the moment because of COVID.
Because of COVID. I don't know how it comes under the label of sexy still, though.
Yeah. I only say it because probably 5 people have responded that way, which, my other interest is psychiatry. And so maybe if I went that way, I would have a better understanding of why those people are calling it sexy. But for the most part,
you can analyze them a little bit more.
It's sort of lost on me. But obviously stuff like public health and stuff like that looms large. I think something we forget sometimes is that your specialty is one choice to make, but your specialty doesn't necessarily dictate the kind of career that you'll have. I mean, if you're a surgeon, you're going to be chopping people, right? You're going to be doing surgery. Like if you're in ICU, you're going to be doing ICU stuff. But like whether you do that 5 days a week or whether you do that a day a week and then you do research or you do teaching or you do sort of public policy work or public health work, I think is really variable depending on who you are. For me, I think that kind of varied career is what interests me most.
Yeah.
The idea of working 5 days on a ward for the rest of my life doesn't appeal. So I think actually having a research interest, doing some teaching, getting involved in public policy would be, I think, probably the kind of career that I would want in medicine.
Yeah.
To achieve that, God knows.
I don't know. But it doesn't surprise me as well to hear that public policy is in there as well. So I don't know, it suits, given everything that I know about you, it makes a lot of sense that could be the pathway that you head down.
It does concern me sometimes that often when people ask me what specialty I want to do, I ask them back. I say, well, what do you think? It's a really good vibe check because obviously there are stereotypes that follow particular specialties. Most of them undeserved, some of them deserved. But occasionally people will say, oh, don't you want to be a politician or something? No. But I think it reflects that kind of interest in public policy. So yeah, like I think one of the really exciting things about working in medicine is that you can do that. You can have a career that's varied. And for me, participating in not just delivering patient care, which is rewarding, but also taking that step back and really trying to see, the wood through the trees, is something that I think really kind of, is very consistent with my personality and the kind of interest that I have is to really. Otherwise, I think you can get very lost in the medicine. I think I'm someone who is doing that in a sense, like you become part of the churn in such a way that you forget about the broader picture.
Right.
And so holding on to that and participating in helping to paint that picture, I think is something that really excites me.
Right. And that's something that's something that makes me a little bit apprehensive about the idea at all of the pediatric emergency, because I looked into the pathway of it, and obviously the number of places in a pediatric training program it's relatively not non-competitive, but it's a lot less competitive than most. But then that's the only entry pathway into then that advanced training program. And then I looked at it, it was like there were 2 places nationally available last year and there was 1 the year before. And it's pretty much been
emergency. Yeah, wow.
And it's like, I wouldn't want there to be, it's good that you said that factoring in the competitiveness and the actual process to getting into those training programs is something that factors in, because for me, the thing that puts me off that is that I wouldn't want it to bottleneck partway through the process. And I don't actually want to stop there. And I absolutely do want to go further. But if it bottlenecks and then I am, say, a pediatrician, I also know that the most common kind of cases that you'd be dealing with are things that don't necessarily excite me. I want to go the step further into the intensive element of it, but doing the checkups on a newborn as they progress through, and that stuff doesn't necessarily excite me. Yeah. I'm much more excited by much sicker children. And so that's what makes me go, well, I also, as a responsibility thing, would not want to do that training, be a pediatrician and not actually enjoy what I'm doing, because it's not good for me, but it's also not good for the patient as well. Like you can't be doing something that you don't care about or that you're not passionate about, as you said before, about like someone doing endocrinology and not realizing that maybe just dealing with diabetic patients 90% of the time is, sorry to put a percentage in your mouth, but like that is an important consideration.
It's a really tricky balance in some respects, right? Because you have to be realistic about what your options are and what your chances of executing those options are. But I suppose the reverse to that is, sure, there may be two places, but there are two people who fill those places.
Yeah.
And so I think particularly through like high school and stuff like that, and like going into medical school, like as you well know, like I went to a high school that hasn't produced a doctor since the mid-2000s. Like the average ATAR is less than 30, et cetera, et cetera, et cetera. Yeah. And there were people during high school who said, you can't do this because our school just simply doesn't perform well enough to produce people to go through that pathway. Like no one's done it in more than a decade. And the attitude that I took to that at the time was, well, bugger it. Well, no one's done it for a decade, but someone's got to do it at some point. Might as well be me.
Yeah.
And I think in choosing your specialty program or choosing which way to direct yourself, having a bit of that attitude is sometimes a good thing. Like it's important to be realistic about your options, but at the same time, I think there are a lot of people in medicine who sell themselves short. It's a lot of negative self-talk. A lot of people really don't, trust that they are good enough to do something, and often that that comes at a huge detriment to them when in fact they actually are good enough to do it and are simply just selling themselves short. So, I mean, the other sort of interesting point to raise about pediatric ED, there being two sort of specialists a year in Australia. I mean, if we think about that logically, in Melbourne, there are 3 pediatric EDs, I think, soon to be 4. Maybe there are 4, actually. There might be 4. Anyway, I don't know. I can't count. Okay. I haven't finished my stats degree yet.
It's coming along.
But it's sort of about 4, I think, pediatric EDs. A lot of EDs, of course, are mixed, right? So like one of our emergency department looks after pediatric patients as well. Likewise, in Sydney, there'll be several as well. Brisbane, there'll be several. Likewise, Perth, Adelaide, Rara. Churning through 2 doctors a year for those EDs doesn't add up, does it?
No, that's what I was like.
That they would need more than that. Even year on year. Obviously, people stay in a career for a long time, but a lot of those doctors are not going to be working full time. They're going to be having the sort of combined career that I talked about. So, that's where our spidey senses should tingle a little bit and say, well, maybe there are other pathways to actually do this job. And there are. A lot of people who work in a pediatric ED might be ED trained,
right, and
then stay in pediatrics. So they like the training program for emergency medicine is a combined training program where you have to do pediatrics. Right. So it may be that those people actually just get a job in ED because they've done that pediatric ED. Or I think the other pathway into it, without knowing a lot about this particular area, would be general pediatrics, but your workplace is actually in ED. You take that sort of job there. You don't have the advanced training for it, perhaps.
Yeah, I was looking at the training program, and I think the advanced training program, the only way to be eligible is to go through basic training in pediatrics and not through emergency. If you do adult emergency, you can't qualify for pediatric emergency. Yeah. So they force you to go through the pediatric path. Yeah.
Yeah, but in terms of the people, at the end of the day, the job that, if that's the job you want, the job is to work in a pediatric ED, just as an example.
Yeah.
It's not just people who have done that training program who work in that setting. It will probably be people who have done emergency training. And it will probably, I think more likely actually, people who have done general pediatrics as an advanced training as opposed to the ED advanced training.
Yeah.
Who then go and work in that setting.
Right. That makes sense. That's making up those numbers because 1 or 2 a year just doesn't make any sense nationally as well.
Yeah, pediatrics is classically one of those specialties where a lot of the care is delivered in the community, and a lot of the care is the kind of stuff that you've described that you don't like. Fair enough. Which is as well, to be honest. But like if you're a pediatrician who works in a hospital, you are looking after sick kids. If you work in a smaller hospital, for example, like we've got, I think, 1 pediatrician on at one of our sites. they will come and see really sick kids in the ED and stuff like that. So there are different ways to sort of, I suppose, have that career. It's just about sort of exploring those options, and those options become more and more sort of obvious to you as you progress through medical school. Like you start to see the kind of, heterogeneity of medicine in a way that, you're like, well, there are actually different. It's sort of like the TAFE pathway after high school, right? Like there's lots of different ways into particular areas of, there's lots of different ways into university. It's not just your ATAR, for example. Likewise, there are lots of different ways into the kind of job that you like in medicine as well.
Yeah. And I figure that's kind of the case, and for people watching as well, like that there's nothing wrong with waiting until you're in medical school, or even waiting until you finish that and moved into internship and do those rotations to really learn more, because that's when you'll be talking to the right people, or you'll be learning firsthand exactly what that particular specialty entails, or what that department entails, and whether or not it actually excites you. So
I think there is some, I could be wrong, but I think there is some evidence. There surely will be, and it'd be worth actually having a look up. I'm pretty sure that there is some evidence that people tend to make decisions about where they want to go after they've left medical school.
Right.
They might have an idea, but actually when they came to the decision to pursue a particular specialty, it actually happens after medical school. Particularly in a system like Australia. I mean, the US, bad luck. Like you graduate.
They have a much stricter process, don't they? Yeah.
Yeah, if you want to be a radiologist, you start your radiology training and internship in the US, which is wild.
Yeah, it seems very quick to make the decision, but
would be great though. It would give you that stability that we don't otherwise have. But
it's true. Yeah,
it's a choice.
And so, well, moving into that, I guess, like looking now, zooming out, as you were saying about public policy and that kind of thing, and having a being able to see the woods for the trees, so to speak. I'm hoping that, I don't really know how I'm going to keep this as a staple component for all interviews on this podcast, but I do hope to have it in there, is to talk a little bit more about broader health policy. And because you've done the MPH and you're looking at that kind of side of health as well, this perfect opportunity. So what do you think, and this might be a very loaded question as well, actually, or a very heavy question, but what do you think? Well, it's not loaded from my end, but just a loaded topic, so to speak. What do you think are some of the greatest problems that are facing healthcare at the moment in Australia, or what kind of challenges is it facing? And then, as well as that, what do you think are some of the things that we can do to work through to solve these? And you can look at that either on the micro level, so in terms of like what can actual practicing physicians do on wards with patients, or you can look at it at the macro kind of policy level as well.
It is a loaded question. It's a very MMI kind of question. You're bringing back in fact, it was a question that I'm not sure if I'm allowed to disclose, but I will anyway. It's a question that I was asked in my MMI many years ago. I think there's a prescribed list of issues that are sort of the big healthcare issues in Australia. Obesity, the aging population, mental health crisis, the gap between Indigenous and non-Indigenous Australians with respect to their health outcomes. Likewise, a similar gap between people who are high and low socioeconomic, et cetera, et cetera, et cetera. There are others. I think look, each of those issues has their sort of individual solutions, often sort of a package of solutions. I think there are probably two key points to make about this kind of idea of there being health issues in Australia.
Yeah.
I think the first is to sort of reflect on the healthcare system and how it's actually structured, particularly with respect to its capacity to actually meet demand for healthcare, which is increasing. That's what the aging population essentially means, that we're having to provide more and more healthcare, in part because we're innovating and there's more and more healthcare to provide, but also because there is, also because there is an aging population with higher healthcare demand.
Right.
So thinking about the actual structure of the healthcare system more broadly is one that's and likewise this works for obesity, mental health, health gaps as well. Our healthcare system is structured in a really weird way in that it has three major kind of funders. We pay for healthcare, like when you go and pay for your scripts or see a specialist, we pay for that. Medicare, which is a federal government funded program, pays for community care, but state governments pay for hospital care.
Right.
So we've got a healthcare system that's essentially run to be really inefficient because community care is cheaper, often more effective as well, and yet there's no incentive to divert care to the community, because if the federal government invests in community care, the state government saves in hospital care.
Right.
And so there's no incentive to do that, because the federal government, probably care more about its own savings as opposed to savings to the state government. And so it's one thing to reflect on. A model that has been raised in the past is to combine those two, such that the federal government delivers hospital care and community care in a way that actually sees care delivered where it should be delivered, which is mostly in the community and less in hospitals.
Yeah.
Always talking about building new hospitals, but we don't need new hospitals. We need fewer. We just need better community care. Yeah. That would solve a lot of these issues. It would make it wouldn't solve these issues, but it would make a healthcare system more able to address those issues. I suppose the second broad point, though, and rather depressingly, is that healthcare only plays a very minor point in addressing health. We all know that back in medieval times, people lived to a sort of median age of 30 or 40. And we know that during the Industrial Revolution, half of kids died before the age of 5. I mean,
I'm terrible on the history, so
crazy, like absolutely crazy. If we think about how that sort of, how our experiences sort of relate to that, it's completely remote to us.
Yeah.
And often we sort of think, well, the big change is, penicillin, cancer drugs and,
vaccines.
Back in the 50s, the way that we treat a heart attack was bed rest.
just take a lie down.
Literally, you'd be like, oh, you're in a lot of pain, have some aspirin and lie down. The aspirin's great, but lie down, probably not. So we sort of attribute a lot of the improvement in health to the fact that we're not telling people to lie down with a heart attack, and we can treat the infections that were killing kids. But the reality is most of that health improvement has come from things like economic growth, which has been enormous since the 19th century. Sewage, like having sewage,
having an actual closed sewage system,
running water, all of those sorts of things. Being able to provide food in large numbers and in ways that are cost effective, which again dovetails with that idea of economic growth. It's probably quite challenging to quantify, but those things certainly dwarf healthcare as a reason for improvements in health.
Right.
So I think it's incumbent upon doctors to have some humility about what their role is and actually how small their role is in providing healthcare. I mean, our job is to fix things when public health goes wrong. Right. Public policy goes wrong. And so I think in terms of actually responding to those challenges of the country, far more important than improving a healthcare system, which does need to be improved without a doubt, is actually reflecting on what are some of the broader, policy implications or policy solutions that will actually address these things.
Right.
Take, for example, obesity, right? Providing fresh, healthy food for people in a way that is cost effective and more cost effective than McDonald's, for example, is far more important than doing surgeries for obesity or any of the medicines we have available for obesity, which just frankly don't work.
So effective, like a lot more, economic controls or buttons can be pressed to actually directly impact health status rather than allowing doctors to do something. Or what about what about the PBS, the pharmaceutical benefit scheme? In terms of broadening that, do you think that is something that is actually a very, directly impactful policy, comparing that to, say, some of the other non-health policy related measures? Do you think that the PBS is a little bit more direct?
Yeah, so for people who don't know, the PBS is the pharmaceutical benefit scheme. It's basically a funding mechanism that subsidizes the price of medicines. Drink break.
Go for
it. Bit of tension. But basically the idea is that there is a cap for what someone can pay for a medicine on the PBS, about $40 for most medicines. if you have any kind of sort of prescribed status, like having a healthcare card, being a senior, the price reduces down to a sort of a nadir of about $5.
Yeah.
Anywhere between $5 and $6 for a script. Obviously, lots of medicines are available on the PBS as determined by a committee called the PBAC, irrelevant to the discussion. There are two ways you could broaden the PBS. One would be to reduce the price of medicines. So rather than paying a maximum of 30, everyone pays nothing, for example.
Yep.
The other would be to put more medicines on the PBS.
Mm.
In terms of reducing the price of medicines, I don't know, is the honest answer. I don't know how effective that would be and whether that responds to a need.
Mm.
I suspect that there would be some people who would benefit from that. There are certainly patients of mine who do not have a healthcare card who would find it really challenging to pay $30 a month for a particular medicine. Like, it's a lot of money. I mean, $30 a month.
And I guess like oncology patients and things like that, where you've got some very expensive medications and things. And so
this is the other part of PBS reform, right? The idea of adding more medicines to the PBS. I don't think there's a persuasive need for it.
Mm-hmm.
The government has added a lot of medicines to the PBS against the advice of PBAC, which is the committee. Basically, for medicine to be added to the PBS, it has to be determined that the medicine is effective, clinically effective, but also cost effective, because the healthcare system, even in a country as wealthy as Australia,
needs to be funded.
Yeah, and actually providing care, which is not a popular point, right? People think that this is, kind of the hard-nosed kind of right-wing approach to healthcare, but it's not. The reality is there is a finite amount of healthcare that we can offer, even in a country as wealthy as Australia. And if we tried to offer all healthcare to all people, it's just not, even when it's not particularly effective, it's not sustainable, and it means that we're diverting care into things that just don't help. And also recognizing that some healthcare is harmful. I mean, healthcare is an extraordinarily harmful thing. It's probably somewhere between the 30th to the 5th leading cause of death worldwide is healthcare.
Right.
Which is frightening. But I think that, oncology medicines are often extraordinarily expensive, and many of them don't offer particularly large benefits. So an oncology medicine that, for example, extends life by 2 months. 2 months is important. Like it certainly, like it is important, and having an extra 2 months of life may be very important to some people, but it may be very unimportant to other people.
Right.
I mean, compared to other medicines which extend lives by years and years and years, what is sort of the cost benefit? And often the case of some oncology medicines, they extend life by 2 months, but they extend a very miserable life by 2 months.
Yeah, that's the thing too. I guess it starts to dive into the very messy kind of process of how do you objectively value quality of life, and then prolonging of life versus quality of life lived, and so on. Yeah. So, and then that's going to be subjective for every patient. So it becomes quite difficult to even start to measure its impact or measure its relative benefit to its cost as well.
Which is precisely what PBAC does. Like the actual decision-making that they make is predicated on sort of health economic modelling of, not modelling, I should say, but health economic sort of parameters, it's not the right word, but numbers that essentially aim to quantify the benefit as a ratio of cost.
Yeah. Which is hitting a particular metric or a particular range, it's going to be approved. Yeah.
And how they do that is sometimes a little bit nebulous. But often we sort of think about, in a country like Australia, the World Health Organization reckons that every quality year should be worth about $50,000. Right. So a full health year is worth about $50,000. In practice, we set it much lower in Australia, around sort of 20 to 30 grand, which is just, it's it's not really where we should be. Like, we're a wealthier country than that. But
yeah, it's strange that we've got such a high GDP per capita and GNI per capita as well, and generally high quality of living. And then we have lower than the global average or the global set standard.
Well, it's not so much the global average. It's based on, there's a formula that takes in GDP per capita basically,
okay,
and aims to set a level of health funding per quality adjusted life year, which is your good year of good health.
Yeah.
Most countries fall below it because it's sort of to be expected that the World Health Organization would want countries to spend more on health. So I suppose there is a bit of bias in it, but
I see. Yeah, that's true.
But nonetheless, for most cancer drugs, they just don't meet that at all. Right? Nearly all cancer drugs, they might cost $20,000 a month for the course.
Yeah, some of them are insane. Yeah,
$40,000 for 2 months, and it's not a quality year, so you lose points on the fact that it doesn't improve quality of life as well. So we sometimes, cancer is a disease that for whatever reason, for multiple reasons, has a sort of special status in Australia. And the kind of decision making we make about sort of spending on drugs in Australia for cancer is one that doesn't even approach the kind of responsible decision making. And I use that term just to sort of paraphrase their own terms that we would use for other diseases.
Yeah.
So yeah, I suppose to get to the original question, I don't think there's a strong argument to make for broadening the PBS. One of the things that the government has done, this one, and actually the previous government, Julia Gillard set up a cancer fund, I think, from memory, has been to fund those kind of drugs outside of the kind of normal approval pathways of the PBS, which I think is really, you don't want to be the kind of person that tells people they can't have their cancer drugs, because it's, the reason that politicians do it is it's extraordinarily politically popular, and it's what the public expect, right? They expect cancer drugs to be available to people, even if they are really expensive.
Oh, well, politically broadening what is on the approved list is a win politically. There's no downside to that.
And that may be appropriate, right? For whatever reason, society privileges cancer as an illness, right? We see it as being perhaps more important as a judge to its impact on people than other kinds of illness. Heart disease is a much bigger problem than cancer in quantitative terms, in terms of, lives lost, in terms of disability, that it causes as well. But we don't spend anywhere near the kind of public attention on heart disease, or even, less so like kidney disease, which is also another huge issue, that we do on cancers, for example. And, that may be appropriate. Society is entitled to make its choices. If it wants to spend more money on cancer drugs and supports that, then, that's up to them. My view, as someone with an interest in health economics, is that cancer drugs should be subject to the PBS.
The scrutiny. Yeah. Fair enough. Cool. Well, I think that was pretty much everything that I had scheduled to kind of pick your brain about. But was there anything else that you wanted to add to what we've discussed? We've had a pretty lengthy discussion, actually.
I'd say it's definitely. And
I hope I didn't take up too much of your day here.
I've been extraordinarily busy in my COVID lockdown.
I wasn't sure.
We've got people to see, things to do, work to get to. There's only day two of my isolation, so it's very much new to me. I don't think there's anything that I need to add other than to say good luck to you as you apply this year. I have no doubt, certainly in our little discussion that we had earlier, that you'll find yourself in a medical school somewhere in Australia. Someone will be conned well enough to have you. No, that's some ordinary stuff. But yeah, look, I think that likewise to the people watching this, I think it can be a really daunting process to apply. And we've reflected a couple of times on this kind of notion of not really thinking that you are worth it and that you can do it. But I hope that people I hope this conversation's helped people recognize a little bit that doctors can be a bit dopey at times, and that are very, very much human. We're not sort of, like I said earlier, we don't have our angel wings on our back. So I think anyone with the wherewithal to actually think about applying is probably suited to medicine. There are very few who go down that pathway who wouldn't actually, make a fine contribution to our profession. So I hope that's something that sits in the mind of people watching as a little bit of encouragement about sticking on that path.
Yeah. I think it's a really, really valuable insight and a really important bit of advice for people applying as well. Yeah, cool. All right. Well, I appreciate the time. And I put in there as well. So I don't know whether or not you'd want to, but if there's anything, if there's any kind of, I guess, social media accounts that you would like to link to people, if people wanted to follow you, I don't know whether or not that's something that you do, but I figured I'd give you the opportunity if you wanted to, and I can put links in the description of the video or anything. If you wanted people to be following your antics on Instagram or LinkedIn or anything like that.
No, I'm a serious man now, so it's
okay.
My Twitter account.
Oh, okay.
I really don't have enough traction on my Twitter. I'm trying to become the serious Twitter poster, but it's not getting enough traction. So they want to give me a follow at Travis Lines, Lines. Go and see some real ordinary content.
Fair enough. Yeah.
But very, very happy. That's probably the best medium for people if they want to ask any direct questions or anything like that. It's probably the best medium for people to get in contact. I'm very, very, very happy to chat with people through their own journeys and stuff like that. I remember the incredible generosity that people gave me as I was applying, and so I'm very, very happy to pay it forward. So if anyone's listening and they just send me a message on Twitter or whatever, I'm very happy to get in touch. And if they don't have Twitter, I'm sure they can give you a buzz and you can get them in contact with me.
Sure. Yeah, appreciate it. Cool. All right. Well, we'll leave that one there, and hopefully we'll catch up again soon.
Yeah, absolutely. Far too long between drinks.
Absolutely. Yeah. Well, we're both in Melbourne, so before I'm leaving, we'll have to do something.
Exactly. Before you slept off to another state.
Yeah. Cool. All right. Easy. I hope you enjoyed this episode of the Dissecting Medicine podcast. Please leave me a comment with your thoughts and share this episode with others that might benefit. Otherwise, thanks for listening, and I'll see you next time.